Good afternoon. This is Lisa McBride, the professor for NUR 160, and I am going to be lecturing today on perfusion. This is the first of two lectures that will cover this huge topic, and want to make certain that you have your PowerPoint that I have set up in SurePath. Make sure that you have lecture one. Should be able to uh, see my notes here. Let me set that up so that you can see. There you go. And you should be seeing my PowerPoint right now. This is again 160 week 8 lecture 1 on perfusion. First of all, let's start off at the very beginning. What is perfusion? What does it mean to you? Uh, we've discussed this from time to time in lecture, and we've also discussed perfusion in our labs when we've done our simulations and things. And to make certain that you know what perfusion is, let's just kind of go over the definition. And the definition is, of course, blood flow. It has a lot to do with blood flow, has a lot to do with how our heart works, how our lungs work, and whether or not blood is getting through our arteries and capillaries and giving the necessary nutrients and oxygen to our cells and then also to our vital organs. So, perfusion is a normal physiological process, and it requires the heart to generate sufficient cardiac output to transport the blood through our whole body from top to bottom. So starts with that heart, starts especially with that left ventricle being really nice and strong and muscular. And then it puts out that 45% or 50% of ejection fraction out of our aorta. And that causes that blood then to course throughout our body. And with that, then it goes to the intestines and picks up nutrients, and it goes to the kidneys to offload waste products and to form urine and to manage our various volumes and processes there. And of course, that blood goes back to the heart and then back through the pulmonary vasculature to go to the lungs, where it offloads the carbon dioxide that it has picked up along its travels, and then to also then pick up oxygen to return to the left side of the heart and start the whole process again. So it's essential to have a good heart and to have good arteries and veins that are clear and that are not all clogged up with all types of debris like cholesterol, and to have no clots or any blood clots anywhere for us to have consistent blood flow. So it's very important then, of course, then for our lungs to also be a part of this. We can't live without our oxygen. We can't live without the nutrition we get from our gut, especially our small intestine. So when you're looking at a patient, we should be able to assess based on what we're seeing and hearing and looking at the skin and looking at their color and looking at their warmth and capillary. Everything that we've put together on our assessment, that is all important for us to be able to determine, is this person perfusing appropriately? Do they have enough of blood flow to the body? And so that's what we're looking at. So here's another picture. This is a perfusion, if you can see in your PowerPoint there. The cardiovascular system, again, is very important for that pump to work. And without the pump working, nothing else works, of course. Our kidneys don't work, our lungs don't work, etc. So we have to have the blood return back to the right side of the heart. And then when it picks up the blood from the right side of the heart and it goes through the right atrium and down through the right ventricle, it goes back to the lungs again, like I said, and picks up our oxygen, offloads CO2, and then picks up a good load of oxygen to go back through the body again. And then it goes back to the left side of the heart and then out to our body. But it's all dependent and interdependent upon the arteries, veins, capillaries, venules, And of course, the veins have valves, and it depends on whether or not those valves are working. So all of this is important. So central perfusion, what is central perfusion? Central perfusion is the term that refers to the action of the heart. That's the central area of our body. It's the heart and large vessels that deliver oxygenated blood to the body organs and tissue. It's a force of blood movement. That is driven by cardiac output, which is the outcome of coordinated effects of electrical and mechanical factors of the heart that move blood through the heart into the peripheral vessels. This process propels blood to all of our organs again and to their tissues from the arteries through the capillaries and returns the blood to the heart via the veins. We approximately channel about 4 to 6 liters per minute of blood through the heart. So our blood in volume is circulating through the heart quite often. I mean, it's going around. I'd love to sometime maybe ask a question. How fast does the heart travel through the body? We've got a total, I think, somewhere is around 10 liters, maybe 11 liters of blood. So about half our blood is going through the body at any given minute, and then the other half is feeding and going to the different places, but then is picking up again and moving on through the rest of the body and the system. Um, since we live here in the state of Indiana and the Indiana 500, I bet you that our blood is going faster than those cars travel around the track at the 500. It will be an interesting question. If I find out, I'll let you know. So, if we have impaired central perfusion, so it means that our heart is not working well, or our lungs are not working well, our heart is a little bit sick, what happens? What happens to our body? What happens to our heart function? And you know, how is the rest of our body going to be doing if our heart's not functioning correctly? Well, a lot of impairment happens with a lot of different conditions. You have a heart attack and there's damage to the heart muscle that can cause a decrease in cardiac output. We do a assessment of that through an echocardiogram, and we look at the ejection fraction that the heart is putting out. Is it less than what's normal? Normal ejection fractions 45 to 55%. A patient that has had a heart attack usually is in the 30s to 40 range, which means they're not putting out as much blood. And if it's below 30, we recommend that that patient has a pacemaker. So, very important for us to maintain the functioning and the beating of that heart because, of course, without the heart, we're dead. So, peripheral tissues can become impaired because of clotting, because of shock, inadequate blood flow, inadequate volumes. So, if we become volume restricted or if we have volume overload, that all puts a strain on the heart. So, it all comes into that interplay of heart, lung, and our central organs. If untreated and our heart continues to be impaired, and it's not getting enough blood to our legs and our arms and our fingers and our toes and our brain, that leads to ischemia, which is basically cellular death and injury because it's not getting enough oxygen and not enough nutrition from the blood and of the body. Just checking my recording real quick here, make sure that we're still recording. Looks like we are. We're doing okay. So our next slide here, we're going to go to the next page. It's cardiac output. Again, a little brief discussion about that. Tissue perfusion is dependent on adequate cardiac output. I think I've said that in different ways 3 or 4 times here. And again, our normal cardiac output is 4 to 8 liters per minute. So again, let's think about what do we recall from our biology class about cardiac output? What affects cardiac output? Okay, yeah, heart rate, arrhythmias, Arrhythmias are those if the blood or the electrical portion of the heart isn't in rhythm with itself, it's not called normal rhythm. If it's an atrial fibrillation or if there's heart block going on and it's not beating the way it's supposed to, then the pump isn't working. It's kind of like the fuel pump on your car. You get a clogged fuel pump or you get a fuel pump in the vehicle that isn't working correctly, the car won't go. It chokes and it hiccups and it will dash forward and then it pauses. That's basically the way our bodies are if our heart isn't working. If our heart isn't working and putting out enough, like in the instance of heart attacks and medications that also slow down the heart, remember the beta blockers, excuse me, beta blockers and calcium channel blockers slow our heart. If a person is overtaking those and their heart rate is below 60, maybe 50, 40, 30, then we have them in an impaired cardiac output. Therefore, they don't have enough output to keep their body going. Patients that go on to beta blockers like carvedilol, metoprolol, Bistolic, to name just a few, will find out that, you know, they feel sluggish when they first start those. Now, beta blockers are great. They work well with heart failure patients that allows them to fill the heart completely. The whole idea is that if we slow the heart down a little bit, then that allows the ventricles, the bottom part of the heart, to fully fill. And then when the heart beats, it's going to increase actually cardiac output. So it takes a few days or a week or so for a person to kind of get used to that feeling. The fact that their heart is slowing a little bit. Maybe they'll get a little winded if they happen to pick up the speed or walking a little too fast. So it's very important for patients to tell us about their symptoms when they start new medications. Myocardial contraction refers to the contraction of the heart. When myocardial contraction is decreased or weaker than normal, then of course our cardiac output is reduced because then again, the ventricles are not pumping. Changes in myocardial conduction, genital defects, myocardial ischemia or infarction, inflammation, or even infection of the heart muscle or pericardial sac can cause abnormalities and decrease our myocardial contraction. Remember that our heart has 4 valves, which play an extremely important part in the normal flow of our blood through our heart. Malfunction of one or more of these heart valves can reduce cardiac output by increasing pressure in each chamber, which then reduces the pumping efficiency of the heart. The major categories of problems with heart valves include regurgitation when valves do not close properly, allowing blood to flow backwards through the heart, stenosis when the valves stick or they get narrow, causing the opening to be narrowed, and then interference with that blood flow. You can each hear of these kind of murmurs that we talk about, regurgitation and stenosis. Stenosis will actually sound like a click, click. So, and regurgitation is almost like a little snore in the heart. So those defects do affect our poor heart from not being able to work efficiently and as it was originally made to do. So tissue perfusion. So tissue perfusion. Okay, great. Just in time for this, I'm going to actually pause for just a moment and see if we can't can't get this phone call to leave us. Okay, we're back. Sorry about that. Always best laid plans of mice and men, right? So tissue perfusion, that refers to the blood that flows through the arteries and capillaries to target tissue. Arterial blood pressure is determined by cardiac output and systemic vascular resistance. Okay, now that resistance can increase because if the person has, narrowed arteries and veins, they've got arterial sclerosis, or they have atherosclerosis in their lower extremities, or they have blood clots or something of that sort, then that is going to have some vascular resistance. If they smoke, then their veins and arteries narrow, and that causes resistance, causing at that point then the blood pressure to increase. But then that puts a load on the heart, and that can cause constricting or dilating the arteries, capillaries, and then we don't get as much nutrition and nutrients and oxygen to our cells and to our end organs. So tissue perfusion is actually, it refers to that end product. It means that our blood is making it into our tissues. It's making it to our fingers and our toes, our liver, our kidneys. It's making it to the skin so that we can get nutrients and oxygen into those areas. If you go look at page 180 in Williams, table 16.1, those are the risk factors for impaired perfusion. We have quite a few of them. So impaired tissue perfusion is, again, the interference with tissue perfusion and reduced blood flow through the capillaries, which are, if they're again reduced, they're not getting the oxygen, fluid, and nutrients that needs. So inadequate tissue perfusion, that results from poor central perfusion or from a mechanism within the vessel or organ itself, such as a blocked or narrow blood vessel, that can cause excessive edema within the tissue, and then that edema is going to interfere with the cellular oxygen exchange. So then we don't get the CO2 picked back up, we don't get oxygen to the tissues, and then we get different colors of the skin and different colors in our capillary refill. The refill will not be brisk. So those are very important things for us to notice. So localized impairment of tissue is often associated with occlusion or constriction of the arteries, which interfere with blood flow to the tissue supplied by the affected artery. In that situation, impairment is limited only to a specific area. Impaired tissue perfusion can also result from mechanisms within, again, that tissue or organ. Example, again, extremities that have edema in them are going to cause things not to be able to exchange well, and veins and arteries that may have a blood clot or some type of cholesterol impedance within the walls of their vessel is going to cause us to have some problems. We're not going to get the nutrients into that tissue, and that tissue is going to not live very well. We can get ischemia, and we can get some necrosis going on if it gets severe. So here's our risk factors that are modifiable and non-modifiable. So modifiable means these are things that we can do to reduce our risk. Non-modifiable are the things that we are given in our package when we are put together as a human being. Now, age, we can't really modify that. We're the opposite of aging is dying. If we don't get older, we die. So we don't really want to modify that one. Our sex, that's determined with our before we're even born. We can't modify that. X, Y, and XX are given to us by our parents. We may try to change the outward appearance and say that we're male or female, but our inward DNA will always be the same. You can't change that once you're born. If you have poor dental health, then yeah, that's a modifiable one. We can go to the dentist, we can have our teeth cleaned. Definitely, if we do not get our teeth cleaned or we have teeth that are in poor repair because they're rotting, that can lead to infections of the heart. It's called endocarditis. And so we want to make sure we're taking good care of our teeth because that gets into our blood system and can cause us to not feel good. It can actually lead to us feeling poorly. An unhealthy diet that leads to now that is something we can control. That's modifiable. We can choose not to go to McDonald's or to a fast food restaurant. We can choose to eat a little bit healthier. Yeah, it's a little bit more expensive sometimes to eat that way, but not really if we plan. We could actually eat more fruits and vegetables. We could actually eat more, drink more water instead of pop. Soda definitely is used to be an occasional thing that we used to eat or drink when I was a child. We didn't drink that much pop because we just didn't have access to it. We would get that for birthdays or from some type of party, but nowadays children seem to drink far too much soda, especially adults. That's the reason why we have in our break rooms, we have soda machines because everybody wants a soda now and then. So try drinking water. Smoking, yes, we don't have to smoke. We don't have to vape. Let's get rid of that if we can, because again, so smoking causes the nicotine to go in through our body, and the nicotine constricts our blood vessels in our veins, which actually lead to an impacting our ability to perfuse and our ability for our heart to work. So very important. And wound healing. I mean, gosh, golly, there's so many things that smoking will do to us. The other factors that are modifiable also happens to be, do we exercise? Do we have stress? Can we exercise to get rid of some of that stress? Yeah, we can. Are we overweight? If we're overweight, then it leads to a higher incidence of diabetes. Um, if we eat a lot of fat and cholesterol containing items that are bad for us, then we can get atherosclerosis. If we don't watch our blood pressure, we can end up having more heart issues. Heart becomes stretched, it becomes hypertrophic when we have a blood pressure that's not in control. So it's something that we can do about is controlling our blood pressure by taking our medications and making certain that we're getting good uh, getting good reports from our physician, making sure that they're checking on us, and then taking the medications or taking the suggestions that they give us to improve our health. Immobility, yes, individuals who are immobile are at risk for impaired tissue perfusion as well, because this includes the paralyzed or the unconscious patient or the one that's in a coma or state of bed rest. Because if they're not moving around, of course, we know that the gut doesn't work as well. We know the kidneys don't work as well, but then also perfusion may be interrupted because sitting or laying too long in one position actually cuts off the blood flow to certain areas. How many times have you laid on your left side at night and then woke up to find your left arm feeling numb and tingly because we've cut off the blood flow to our arm? So it's very important for us to move those patients every 2 hours to make sure that they're not always on their back, that they get turned to side or to get up in a chair. We know that immobility increases our pressure ulcer issues as well as venous thrombi, which are blood clots, DVTs, uh, deep vein thromboses, and any extremity. It doesn't have to be the lower limbs. It could be arms, it could be fingers, it could be anywhere. We know that a blood clot to the heart is called a heart attack. A blood clot to the brain is called a stroke. So those things can be avoided to a certain extent if we can end up being more mobile and making sure that we're not at risk. If you take long airplane flights, it's recommended that you get up and stand up once in a while, walk around, use some type of um, support hose or something of that sort to keep the blood flowing, because those long flights have led to people getting blood clots because they're not moving around. If you're flying all the way to, oh, let me see. If you go from Indiana to Atlanta, that's not too bad. That's a couple hours. But if you go to Atlanta and go to Rome, Italy, it's a good 11 to 13-hour flight. That's a long flight to be sitting on a plane. So believe me, get up, move around. So what are the, again, non-modifiable? Look again. Take a look at this chart. Know your non-modifiable uh, uh, issues with perfusion. And note the age, non-modifiable, sex, non-modifiable, genetics are non-modifiable. And then also, if a person has certain disorders in their blood and hemoglobin, such as sickle cell, which is a genetic predisposition towards that with our patients, that's an abnormal hemoglobin that actually clumps because of the shape. It's not shaped normal. It's in a sickled shape instead of being a round shape. And those particular hemoglobin cells or red blood cells will clump together, causing a clot and closing off perfusion in different areas. So, very important to know this history when we talk to our patients. In Giddens chapter 16, the concept of perfusion and problems associated with impaired perfusion covers a wide range of physiological processes and conditions. The scope of perfusion ranges from optimal perfusion to no perfusion. Variations in perfusion are seen among individuals along their lifespan with multiple causative factors and a wide range of effects and duration. So it's very important that, again, I'm going to go back to this, want to make sure that you look at this. Note that it covers stress, coping, pain, cognition, elimination, gas exchange, clotting, mobility, all these different exemplars, inflammation, patient education, intracranial regulation. Hey, it even controls our brain. If we don't get enough perfusion to the brain, we have a hard time thinking. If we have no perfusion to the brain, we may not have any thinking at all. So, very important for us to keep up with that. All righty. Let me make certain we've covered everything that we need to know for this. Make sure you look at my notes there. I don't like having to read word for word of what I've written, but I want to make sure you have everything. And patient education, that is it's central to the prevention and management of cardiovascular disease. So we need to make certain our patients not only are told to stop smoking, but told why. Sometimes when we know why a reason, it's not just because of, oh, we tell you so. You know, you tell a child that, you say, why can't I do that? And you say, well, it's just because I told you not to. Well, let's tell them why. Your perfusion, your end organs, your heart, your lungs, your kidneys are all going to be affected by that cigarette smoke. And if you want to have a good life and feel good and be able to enjoy your old age and get around, then don't smoke. Okay. When we talk to our patients, it's very important for us to get a very good and thorough history. You've been focused on focused assessment. Last term, you learned how to do a full assessment. But this term, we've been breaking down the assessment parts into different little packets so that when we go back and we talk to a patient or we have an issue, we know what we're actually assessing for. With perfusion, unfortunately, it covers a wide range of things that we have to assess. Our examination is not going to just be cardiovascular or heart. It's going to also cover skin. It's going to cover lungs. It's going to cover the end organs. What is the color of the skin? What is the warmth of the skin? What are the temperature? What is the capillary refill? So it's very important for us to be noting things such a history. Do they have pain? Do they have pain with walking? That tells me a lot right there. If they have pain and they start having claudication, which is the word for having pain in the calf when you walk too far, that means that you're not having good blood flow to your legs. If you're having dizziness, syncope is that interesting word, Cyncope, which means fainting. And we really don't know what the fainting is caused by, but there's multiple causes, and a lot of those have to do with blood flow. Dyspnea, which is shortness of breath, edema, swelling, bleeding, and bruising, and fatigue. We need to look at all of these factors when we're doing our assessment and to be looking at our diagnostic tests. The diagnostic tests that we're talking about include EKGs, echocardiograms, cardiac MRIs, maybe going even to the cath lab. Also looking at pulmonary function tests because are the lungs doing their job? So those are all things that we'll be looking at as well as blood tests. So we need to first of all get a baseline history. What type of subjective data are you going to collect? Think about that for a few moments. So we're going to be asking the question to our patients, tell me about your health. Tell me about your past history. Tell me about your family history. What about your personal and psychosocial history? So patients present with questions and diseases of all sorts. They present with diabetes. They may present with renal failure, hypertension, hemophilia, strokes, heart disease. As nurses, we need to ask them about their current medications and also to ask for that list Do they have a list of those medications? Do they have a list of the over-the-counter medications, herbs, and recreational drugs that they have used? If they've used cocaine, cocaine hurts the heart. So does a lot of the other drugs, such as even marijuana can actually uh, narrow blood vessels and passages and can also upset the lungs because they're putting smoke where it doesn't belong. So it's going to do some damage. It doesn't matter if it's just it's only just marijuana. No, you're putting something foreign into your system. We'll ask family members about their history too, because a lot of the genetic things that we need to know also come from, did their father or their mother have hypertension or high blood pressure? Did they have heart attacks? Did they have strokes? Did they have blood clots? What about grandma and grandpa? Do you recall if they had any of these issues? Did they have a history of syncope or fainting? Or have they had a TIA or transient loss of consciousness? Or the almost a stroke? Have they had headaches, numbness, confusion? Have they had a cerebral emboli, which is a blood clot in the brain? Ringing in the ears may indicate an inner ear problem, so we ask about that. Patients may report feeling dizzy. If the dizziness occurs when the patient sits up suddenly, we call that orthostatic hypotension. And again, the definition of orthostatic hypotension is a 20 millimeter per mercury drop in systolic blood pressure or more. It could be 20 to 30. So if a person is normally 138 when they're sitting down and we got a systolic pressure of 138, if they were to stand up and their blood pressure drops by 20 points and it drops to 108, they're going to be dizzy. They're going to be dizzy even at 118 because it dropped 20 points. So that's the reason why we ask, what is your normal blood pressure? Do you notice that you're getting dizzy when you stand up and move from a chair to your comfy chair, or from bed to standing up? Dyspnea is inadequate circulation of the blood interferes with oxygen transport to the tissue. So dyspnea um, messes with our breathing. And if we're not getting enough oxygen into our system because we're short of breath, then that also decreases our oxygen delivered to our end organs and as well as our system. If they have indications of an intracranial bleed, which includes the complaint of the worst headache they've ever had in their entire life, any changes in vision, sudden difficulty talking, or weakness of one arm or a leg on one side of the body or the other. Those are things we need to know. Fatigue. Do they feel tired more than they have in the past? Is it a lack of energy that is new? And maybe the onset of fatigue is at a certain time of day, or is it towards the evening when they're more tired? With right-sided and left-sided heart failure, a gradual onset of fatigue with acute blood loss that also causes fatigue. So our patients can have fatigue if they're having hidden symptoms of the condition that they've been diagnosed with, like heart failure, or if they have also had anemia, or they have some type of nutritional impairment in their intake. They're not eating enough good foods. What are you looking for in your assessment of a patient with potential inadequate perfusion? So, again, as we're doing our physical assessment, it's very meaningful for us to obtain those vital signs. Vital signs are not just something we just do because, oh yeah, we learned to do that in nursing school. But no, we do it so we can use it as a tool to see how the patient is doing. We want to look at their oxygen saturation. We want to look at their capillary refill. We want to look at their skin color. We want to feel to see whether or not their skin is warm or is it cold, especially in their feet or extremities. When measuring blood pressure and peripheral pulses, we may note changes such as hypotension and hypertension, bradycardia or tachycardia. With severe bleeding, we may see tachycardia at first, and then peripheral pulses would be equal bilateral or should be equal bilaterally. So we want to make sure that they are equal. That's the reason why we compare from one side to the other. So we are going to check our radial pulse on the left wrist and our radial pulse on the right wrist. Are they equal? Or is one side threadier than the other? Is one side absent almost? Then the same thing with our legs. We'll check tibial and dorsal medialis, and we'll compare. Do we have a good tibial pulse? Do we have a good femoral pulse on both sides? That tells us whether or not we're actually perfusing equally on each side, or whether or not there might be a blockage on one side or the other. So when we inspect, we're inspecting the entire skin, and we're looking for discoloration. Do you know what petechiae is? It's Petechiae, petechiae. Petechiae are those little red dots that appear on the skin, and it's from the capillary system having a little bit of oozing of the blood. Ecchymosis, that's bruising, of course. We're looking for bruising. And then we're also looking for any type of bleeding into the subcutaneous tissue. Now, it could be from medications they're taking. They could be on blood thinners, warfarin, prednisone, Eliquis, rivaroxaban. So we need to be asking about those. Pale skin may indicate anemia. So we want to also check their blood system for folate and iron, or their hemoglobin. Is their hemoglobin low? We're going to look at their neck and their chest. We're going to listen to their heart. We're going to listen to their lungs, inspect the upper and lower extremities and symmetry. Is the skin intact? Is the color normal? Or is there ruddiness in one arm or a leg different than the other? So if there's asymmetry, which is meaning that they're not equal, then we should be noting that. Is the color normal for their race and ethnicity? Then we should be making note of that too. How do you palpate the apical pulse? Do you recall how you palpate and listen for that pulse? Okay, that was the fifth intercostal space midclavicular line on the left side. So we should be listening to that right over that area and then be counting it and seeing if it's nice and strong. When patients have ventricular hypertrophy, their enlarged heart may move that point of maximal impulse. So it may move laterally. So we may find out instead of it being in the midclavicular line, it may be further over towards the axilla where we hear it the loudest. So that's very important for us to note that. Has it moved? Check the EKG. We want to make sure that if we hear an irregularity in the rhythm of a patient, then someone should be checking EKGs and seeing what is the rhythm. Do they have premature atrial contractions, which are called PACs? Are they having atrial fibrillation, which is the fibrillation of the atria that reduces the amount of blood flow and interrupts our heart rhythm? If they have edema, they may report that their socks leave an indentation around their legs. And that's the reason why they don't wear the support hose or the support socks. But they need to wear those in order to return that fluid back to the central part of their body. They need to elevate their legs once in a while to get that edema out. So we need to be able to check what is their weight. Again, remember the heart failure patients, we need to be checking their weight on a daily basis. And then again, bleeding and bruising. Is there something unusual about their bruising? Is it more than them just hitting something? Do they just have bruising that just happens to appear? And do they have sometimes bleeding from their gums, bruising of their teeth, nosebleeds, or black tarry stools? Those are very important things for us to note, as well as blood in their, if they're throwing up blood or blood in their urine or coughing up blood. Again, we need to be asking them. If you don't ask, we didn't assess. So our diagnostic tests, we got quite a few of these, are normal for some of these, like the serum lipids, LDL or LDH. Lipoproteins, LDL, is supposed to be low. That's our low lipoprotein, and that is the bad one. That's the one that can interfere with our heart. We want to make sure that it's less than, our book says less than 70 milligrams per deciliter. And then for HDL, which is our high density lipoprotein, which is our protective, that's the one that helps our heart and it removes lipids from the endothelium. That one should be above 55, 50, so it's run through there for women. And then we talk about cholesterol and stuff. We need to know the cholesterol count also, which is not listed here. Complete blood cell count, we've talked about that. That's our CBC. And the CBC includes our white blood cells, which indicate infection, or it can indicate that whether or not the patient has leukemia or some type of anemia, if it's real low. Red blood cells specifically should be in normal levels. Our hemoglobin and hematocrit is also used to diagnose whether or not a person is anemic or if they have polycythemia. It will affect their heart, their blood volume. If they have polycythemia, they produce too many red blood cells or too much blood, then their volume of blood is going to be higher. And that can put a strain on the heart as well. Blood coagula blood coagulopathy or blood coagulability is the process where the blood actually can clot. If they're on any type of blood thinners like warfarin or Coumadin, which is listed here, or if they're using heparin, or if they've got Lovenox, or if they've got Eliquis or rivaroxaban, then their blood is going to be thinner. They're going to have a little bit different INR and PT for warfarin users, and then Eliquis and rivaroxaban is not going to be noted on there. But if they do, then we need to be watching for bleeding and also for bruising. Or bone marrow biopsy. That is also used sometimes for us to be able to tell whether or not the person has normal blood cell production. And it tells us, because that's where our blood cells are stored, that's where our blood cells originate, that we need to know how that is working sometimes. Electrocardiogram, there's our ECG that tells us what our electrical impulse is through the heart. Is it regular, or do they have a dysrhythmia? Cardiac stress test, we put this person on a treadmill and say, here, walk for so long, and then we increase the incline and increase the speed, and we check to see if they have, while they're on the EKG with that machine, it's going to tell them if they have any type of cardiac stress, and it tells us whether or not they have some heart damage due to either previous unknown heart attack, or if we knew they had a heart attack, or how are they doing? Is their heart coping? Chest x-ray is going to tell us whether or not the lungs are clear, whether or not we have any problems with the bones, or the problems with the rib cage impairing the lung action. Ultrasound, that is we can use that of the heart. Again, that's an echocardiogram. Or that can tell us whether or not the valves are working, whether or not they're regurgitating, or if they're stenotic. It can tell us whether or not we have any type of blood clots in the heart. Arteriogram produces visualization of the arteries by injecting a radiopaque, which is, again, a contrast media, so that we can actually see if there's any occlusions or any blockages anywhere. We could do that to look at the cart. We can use that to look at the legs or the arms to see if there's a clot in the legs or the arms of the patient. So management related to perfusion, the primary, secondary, clinical management, collaborative interventions. There's a huge number of people that get involved with this. So it's great for us to be able to promote heart and health with vascular. Again, maintaining a healthier body by not smoking, increasing our walking, wearing anti-embolism stockings or support hose, making sure that the patients get up and move around, that they are prescribed anticoagulants if they're not getting up and moving around. So our primary prevention includes measures to promote health and prevent disease for perfusions. Those include promoting heart and peripheral vascular health, as well as preventing abnormal clotting and bleeding. Our secondary preventions are our screening. That includes the screening and early diagnosis and prompt treatment of existing health problems. It proposes to shorten the duration and severity of consequences. Routine screening involves monitoring blood pressure and serum lipids. That's our blood work that we should be getting at least once a year. Checking our blood pressure, making sure everything is normal with it. If not, then why aren't we taking some medications? If we're overweight, getting our weight back down so that we can do better control. Our clinical management, now that's associated with perfusion, involves the prevention of illness, early detection, and appropriate collaborative management of cardiovascular problems. The clinical management includes primary prevention and secondary prevention and blood pressure screenings. So we do offer blood pressure screenings in a lot of the facilities and hospitals where we tell patients, just come in, we'll be happy to check your blood pressure. Of course, they've got sometimes a blood pressure cuff at CVS or Walgreens where people can get their blood pressure readings. So our collaborative interventions in perfusion, refers to strategies and actions taken to enhance blood flow and ensure adequate oxygen delivery. These usually include more monitoring and assessing, checking vital signs of blood pressure to identify any signs of impaired perfusion. That's making those patients come in a little bit more regularly. If they have high blood pressure and they're taking a new prescription for medication, we should be having them come in every couple of weeks to have their blood pressure checked. Is that medication working? Do we need to tweak it? With medication management, again, we want to improve circulation, such as vasodilators or oxygen therapy. So if they have low oxygen saturation below 87%, if they're doing a walk test and they maintain below 87%, we should be getting them on some oxygen. And then, of course, patient teaching. That's part of the collaborations. We have to be able to teach the patient and the patient then teach back to us to make sure that they understand. Surgical interventions, in the cases of blockages and procedures of that sort, then it's angioplasties, bypass surgery may be necessary, so open heart. And then nursing care planning. That's when we get into place developing a care plan that focuses on optimizing their tissue perfusion and preventing complications. So it's very important that we pass this on to the patient and with their help, come up with a goal or plan. So let's talk about the collaborative interventions that we can do. Nutritional therapy. Now, again, here we have a recommendation of having a heart healthy diet, lower sodium, lower cholesterol, to lower lipid levels, losing weight and maintaining optimal weight. So nutrition, we want to get our dietitian in place if we could possibly do that. Again, smoking cessation. Indiana does have a 1-800 smoking cessation phone number that we can also provide. And they provide all types of support for patients and to make sure that they can get off the cigarette smokes by smoking by using either the patches or the gum. Not all insurance pays for that, unfortunately. And then we talk about activity and exercise, including a walking program. The person doesn't have to go out here and kill themselves and jog. If they just get up and walk for 10 or 15 minutes a day, that would be helpful. That would be the first start. We talked about earlier in one of our, I think that was in 163, we talked about Tai Chi, and we talked about keeping the patient mobile. That was our focus this week in 163. Mobility is important. If that patient has had a heart attack, we have actually cardiac rehab programs. Community Hospital, St. Vincent's and Methodist Hospital has a program where if a patient has had a heart attack, they can actually go in and insurance will cover this for, I think it's 4 to 6 weeks, where 2 days a week or 3 days a week, they can go in and with the nurse there, they put them on a monitor and they give them a bicycle or they put them on a treadmill and say, they're trying to get them rehabbed, basically getting them back to some mobility so that they can improve their heart output, cardiac output. So it's very important for them to participate in cardiac rehab. if that's available. Pharmacotherapy, of course, refers to the medications that we're going to end up giving. Sometimes we can't surgically intervene for a patient, so we actually intervene by giving them drugs and do a drug therapy only. There's positive inotropes. Those are medications that increase the myocardial contraction strength. Common ones of those are dobutamine, milorone, and digoxin. Digoxin, again, is the same as digitalis. That digoxin uh, increases contraction of the heart. Now, with digoxin, we do need to check for toxicities because we talked about that sometimes different electrolyte imbalances and volumes and stuff in our body will change and it will cause digitalis or digoxin to be more toxic. So every now and then a patient needs to have a blood test to check that. Vasodilators increase the diameter of blood vessels, and they are used to treat those patients who have hypertension and angina. Common examples of those include, of course, our ACE inhibitors, such as captopril, lisinopril, and our ARBs, such as losartan. Then we have nitrates, and those are amyl nitrate, nitroglycerin, nitroprusside, potassium channel activators such as diazoxide oxide and minoxidil. Minoxidil may be familiar to some of you. Minoxidil happens to be that medication that can help with other things too of a sexual nature. So that allows vasodilation. Okay, vasopressors, we're talking about those decrease or constrict the diameter of blood vessels. They are used to treat hypotension resulting from hemorrhage. Now, I have these all in a list here. You need to be putting these medications down and add them to your repertoire because vasopressors and inotropes, all of these medications I'm discussing could possibly be on your tests. I haven't seen the test for the final test yet, but I do know this. Next term, in term 3, you have a HESI, and it's going to be over drugs only. You need to get these drugs down and look at them, know what they're used for, know how they work. Vasopressors are used to treat hypotension resulting from hemorrhage or myocardial infarction or septicemia. Those particular drugs are in epinephrine, norepinephrine, and dobutamine. So make certain that you know what those are. Put them down in your cards and start looking them up. Then you have your diuretics. Those promote they remove excess fluids out of the system by excretion through the urine and preventing reabsorption of sodium in the kidneys. Those are used to reduce blood volume to treat hypertension. Common examples, of course, are our loop diuretics, which again, you should be having these written down. Furosemide, our thiazides, such as hydrochlorothiazide, HCTZ, and then our potassium sparing ones again are spironolactone, alprazolam, aldactone, and then our osmotic one is mannitol. Let's talk about antidysrhythmics. Those help correct erratic electrical impulses. So they help calm the heart's electrical rhythm. Those are used to treat premature ventricular contractions, tachycardia, hypertension, and atrial fibrillation. Those agents act by blocking electrolytes that affect electrical conduction in the heart. And one of the big ones is amiodarone. That's spelled AMIODARONE. And then there's diltiazem, which is also a calcium channel blocker. Or there's also atenolol, which is our beta blocker. That's our blocking beta adrenergic receptor, atenolol. Remember, our beta blockers end in LOL. Then we have cardioglycosides. Those have a positive inotropic effect by lowering the heart rate to increase cardiac output. Those, again, that one is digoxin. Digoxin is used a couple of times here. And then there's anticoagulants. Those prevent our blood clotting. And again, you should know these. That's warfarin, enoxaparin, digabatrin, and rivaroxaban. So we're talking Plavix. So all of those, even the platelet inhibitors. And then the antiplatelet ones are the next ones I'm going to talk about. Those antiplatelet ones are tirofiban, which is a platelet inhibitor, and oh, if I could just pronounce these, dipyridamole, and that's spelled Dipyridamole. And then the thrombin inhibitor, bivalodruran. Um, then we have the easy ones, aspirin and clopidogrel again. Thrombolytics, they disrupt blood clots. Again, see my notes because these are all in the notes. And then the anti-lipidemics, those are your cholesterol medications. Atorvastatin, lovastatin, pravastatin, those are all those things that you need to look at, that the pharmacotherapy is huge. Again, medications include everything from vasodilators all the way to the anti-lipidemics. So make sure that you get those kind of written down, know which meds are in which group. Defibrillation. That is a procedure that we use to shock the heart if we have a cardiac rhythm that is not normal and the heart is not actually being controlled by the SA node, then our goal is to shock the heart, stop it for a moment, and then restart it again so that it'll end up being in the correct rhythm. They use that with SVT if a person has severe 180, 240, and they're symptomatic with their heart rate. Then we can shock it and hopefully get it back into rhythm. Pacemaker, that's actually an implantable device, as well as defibrillator. That could be a defibrillator would be put in, that's a bidual device, is the defibrillator. So the defibrillator device and pacemaker device can be in one device. So they can actually have a defibrillator that also will shock if the heart is in a rhythm that it notes that is not regular. And then it also can pace the heart to keep the heart beating at a certain rate. The doctor will set, 64 is the threshold. We want to make sure the patient has a heart rate of at least 64 or 74 or 80. And then the pacemaker actually stimulates the myocardium to beat. Both of those have to be surgically emplaced. The person should also carry around an identification card that lets us know that they have those. You will note that when you do your assessment on the patient that they will have an area, a bulge. Now that could be on the left side or it could be on the right side. So you need to ask the patient, do you have a pacemaker or a defibrillator, or is it both? Is it a dual action defibrillator pacemaker? And they should know that. They should have been taught that. So again, ask your patient. Endarterectomy, that's a surgical procedure for removing a plaque or a blockage from the lining of an artery. Thrombectomy, that's also a procedure that we surgically remove a thrombus from a vessel or a blood clot from the vessel. And then cardiac transplant, that is actually replacing the entire heart and the main attachments to the heart. So the donor heart is put into place. The person is put on a bypass machine that's all hooked back up, and then it's actually electrical shock to back into rhythm, and then they are taken off their bypass at the end of that procedure. Heart valve replacement, arterial bypass, graft, angioplasty with stent replacement. Here again are other procedures. There's a lot of heart procedures. Heart valve replacement, again, just like it says, that's when we replace the valve. That could be any of the valves. It could be mechanical, or it could be actually pig valve. We have human, bovine, porcine, and human cadaver valves that sometimes are put into patients. And so those patients, again, should know which valve they had. They should carry a card around with them that lets them know. Some of these patients may have to have special anticoagulants that they're using while they're on that, if they have a valve of that nature. And then they should also be on some type of antibiotic if they're having, their teeth cleaned, or if they should know which one. Their doctor would have told them, yes, you should have antibiotics before having any procedure, or you need to be taking this anticoagulant for the rest of your life. Arterial bypass graft, that is the most common procedure that you have out here. A lot of people go back to the cardiac lab to have coronary revascularization through a bypass graft. And now they can have that done where they go to the heart catheterization where they clean it out, or they can also have bypass where they have actually a surgical procedure, an open heart, where they go back and they can have one artery, two or three or four, even. But I've actually seen bypass grafts times 5 in some patients, and so they will tell you how many, if it was a bypass 5 procedure that they have. And again, that is a surgical procedure to help restore the blood flow to the heart itself. And so they bypass the patient's blood work by get it going around where it's clotted and put a different vessel or a different vein or artery in to bypass. It's just like a detour. You go out here and you get on 465 and you get off onto a smaller road and they said there's a detour ahead. Well, that's exactly what they're doing. They're making a detour around where it's clotted, and they attach from one end to the other end so that they can restore blood flow to that part of the heart. Angioplasty with stent replacement. Okay, that is the one with the cardiac cath lab, and my husband actually happens to have 5 of those. So after they have a heart attack, sometimes they'll take them back to the cardiac cath lab and they'll see which of the arteries are causing the issue, and they'll actually put a stent in there to open up that particular blood vessel by making it wider. Quite fascinating. You can find those on YouTube if you want to watch how those work or how the stents work. It's like building a new bridge and opening it back up. So let's talk about hemophilia, sickle cell anemia, deep vein thrombosis, and pulmonary embolism. These are going to be some exemplars. We'll cover those on each slide, and we'll talk about the patients that may present with these. These are the patients that you may see and the things that you need to know as a nurse to be able to help them. So let's go to the first one. There's basically 3 types of hemophilia. Hemophilia refers to a group of inherited bleeding disorders caused by gene mutation. It leads to the absence or ineffective production of a clotting protein. So take a look at Giddens, page 194, or Saunders, page 386. The 2 most common types of hemophilia are factor VIII, which is V111 deficiency, hemophilia A, and factor IX deficiency, which is hemophilia B. There are also other types of bleeding disorders, but these are the ones we're going to talk about. Hemophilia A is the most common type. It affects over 5,000 births of people assigned male at birth. And then hemophilia B is also called the Christmas disease. It is 4 times less common than hemophilia A. And then hemophilia C, also called Rosenthal syndrome, it affects 1 in every 100,000 people. So as you can see over on the left, there's a normal blood vessel with platelets and clotting factor. And then we have one that's not normal there on the right, where the hole where it's gone all the way through. And we have someone that can, they're going to bleed because they don't have a clot to be able to heal that up or to be able to cause it to seal. Most bleeding disorders are genetic, meaning they are inherited and passed down through the family. Some, however, are acquired, meaning they develop later in life due to other things, like you get some type of autoimmune disease or a certain condition, and then it causes you to lose the ability to produce certain clotting factors. In most bleeding disorders, severity is determined by the level of clotting factor and activity. Lower levels typically indicate more severe disease. This is known as acquired hemophilia. Hemophilia A, that's also known as classic hemophilia, is a recessive disorder where people lack or have low levels of factor VIII, a protein crucial for clotting. About 1 in 5,617 males. You notice A is males have hemophilia A at birth, according to the Center of Disease. That's the reason why this is recessive, because it's found on the sex gene of the Y gene. And it mainly affects males. Now, females can be carriers, but they won't have, and well, they don't typically have the symptoms like the males do. Hemophilia B is deficiency of factor IX. So, factor IX people, also called Christmas disease, lack factor IX and are born with it. There's about, like, again, they say about 5 in 100,000 males are born with hemophilia B worldwide. Early signs of hemophilia. Symptoms are based on severity again. Babies with severe hemophilia A may be diagnosed at birth or shortly after. The bleeding disorders may be diagnosed in children or adults when a small cut continues to bleed for longer than usual. So the child goes out and they get a skin knees, or they have a nosebleed, and for some reason there's no cause for it. They just start bleeding. They bruise very easily. They're bleed excessively during dental procedures. As soon as they hit the gum, they start, bleeding. Their joints become swollen or painful. Those with mild or moderate bleeding disorders may not be diagnosed until after they, leave childhood and they actually enter adulthood. Some people with bleeding disorders may be diagnosed only after they experience excessive bleeding, and if they have a small cut, again, they continue to bleed, and that's when mom and dad notice. Other health conditions and some medication can cause similar symptoms to hemophilia, so we need to be looking at the entire information. What medications are they on? What have they started? And to make certain that we assess that. Again, it's quite interesting that infants may show signs shortly after birth because they will have excessive bleeding from the umbilical cord. And of course, then they can check that out to see if that's what it is. So here's again a slide with symptoms of hemophilia A, which is nosebleeds, bleeding gums, swollen joints, bruises, coughing or vomiting blood, blood in the stool, heavy menstrual cycles. People living with hemophilia may experience both internal and external bleeding. It can present later in life. Like I said, they may not even know they have it until much later. Some people may only have bleeding only after they have something severe, like surgery, dental work, or an injury. So that's when they get noticed. Bleeding, common symptoms of hemophilia include bleeding into the joints and muscles, which may, again, reduce their mobility. Blood in stool or urine, frequent or prolonged nosebleeds, spontaneous bleeding, throat, nose, other areas. And then, of course, pain it looks like pain is about 57% of the people with those bleeding disorders, and about 71% report pain that impacted their sleep. So it's quite interesting. Those folks that have hemophilia, a lot of them will have depression. They will report experiencing fatigue and anxiety. So be aware that they will come with their packet of information as far as that they just don't feel good and they're scared all the time about bleeding. I would think it would be very difficult to live with that condition. So here's the diagnosis and treatment. So there is no cure. We tell patients, of course, to avoid injury, if to make sure that they're having good nutrition, that they do get good dental hygiene. They do have IV administration of the clotting factor as needed. And then they need to, of course, report any prolonged nosebleeds or any intracranial hemorrhage or any bruises and stuff, and to make sure that they meet with their doctors as often as they can to be followed up on. Um, they will determine exactly which clotting factors that they are short on. And like I said, they are working on some replacements out there, but they don't have quite a few of them. There is on-demand therapy where they can administer during bleeding episodes. And then, of course, prophylactic infusions, they can do that in order to cut down on bleeding into into joints. Desmopressin can treat mild hemophilia. That's a hormone that stimulates the body to release more clotting factor. It can be injected slowly into a vein or used as a nasal spray. A medication called hemizumab, yep, that's a modified antibody drug, is a newer one. It's called Hemlibra, and that particular does not include a clotting factor, but that drug can help prevent bleeding episodes with people with hemophilia A. Um, there are some fibrin sealants that they can use. It looks like uh, desmopressin is the hormone that can actually stimulate the release again. So make sure you've got that one written down, that you know desmopressin and the antifibrinolytics and things that they are using these days. So here's an example of hemophilia and inheritance. Father without hemophilia, mother who is a carrier. So they could have a daughter who's also a carrier, or they could have a son who has hemophilia. That's why it's recessive again. It's actually recessive. I said on the Y. No, it's not. It's recessive on the X. The mother is the carrier, and then the father and mother get together, and the mother can pass it on to her son on the X chromosome that she provides. Here you have another example on the right. It's the father who has hemophilia. Again, it's on the X chromosome. The mother is not a carrier, but then they will have, because it's on the X of the father, they will not have any children that have full blown. They'll have two daughters that are carriers. And then here's a father and a mother, one with a father who has hemophilia, who marries a woman who is a carrier. Then they will have actually two children that have hemophilia, including a daughter and a daughter who's a carrier. So you can see how the inheritance goes. That's quite interesting. I'm not really for sure if they're going to have something like this on the exam, but definitely I would know that yes, it's carried on the X chromosome, and it is a recessive gene, meaning that it takes to have a child, you have to, at least have one child that inherits the mother's X in order to have it. And then if the father is the one who's the carrier and the mother is not, then just the children, the daughters, are then becoming a carrier. So it's quite interesting. Genetics has always fascinated me, and so this one is a quite interesting issue. Now, with these patients, definitely you want them to. I don't think football would be a good sport for these young men to play. They need to find a sport that's not as rambunctious and can cause damage. Same thing with a young lady who has hemophilia. Definitely needs to be a low impact type um, sports. I do know children that have hemophilia that do participate in sports, but it's typically, like I said, things that are like, oh, walking or bicycling, or, they can play tennis and stuff. But again, if they end up having joint issues or things like that, they're going to bleed into their joints. They need to avoid medications and such as over-the-counter steroids or steroids, aspirins, non-steroidal anti-inflammatories. Again, they're number one recommendation for pain is acetaminophen or Tylenol. Again, remember, Tylenol is not a non-steroidal anti-inflammatory. So that's why they can take that particular one. And they need to be monitored very closely for cuts and bruises and injuries. They need to be able to apply pressure, but to make sure that they get put an ice pack or an ice pop or something on the area will also lower the amount of bleeding. Um, Sickle cell anemia is our next. Again, here is an example of sickle cell. I told you it was a abnormal. Our normal is on the right. We see it's nice and round, kind of concave. Then the sickle shaped is there. You can see that this particular condition can get into the smaller blood vessels, the capillaries, and then it can cause clotting and clumping of the sickle cells, blocking the blood flow and cause pain. Here we have a genetic chart again. If the father has got the trait and the mother is normal, then they will have a possibility of two children uh, that also have the trait of sickle cell. This is male and female. They don't have to be one sex or the other. And then we have mother and father both with condition. They're going to pass it on to all four of any of their children. It doesn't matter which child. If they both have the sickle cell trait and they have sickle cell anemia, then they're going to pass that on to every child that they have if both of them have that trait. If you have a father with sickle cell and the mother is normal, then they're going to have children that it will have the trait. That means that they can pass that on. If they have a father with sickle cell anemia and the mother with the trait, then they're going to have two children that have actually sickle cell and then two that have traits. So that's what the way to read this. Sickle cell, that means SC, that means that patient has the sickle cell. T means they have the trait for it. That means they could possibly pass it on if they have a spouse that has that trait or has actually the sickle cell itself. Review Giddens, page 194 for more information. Sickle cell prevalence, like 1 in 100. It's basically a race comparison chart. You're going to have a higher number of people, of course, of African American descent. 1 out of every 500 African Americans will have the trait, or may have the actual sickle cell disease. That's quite a few. And then 1 in 1,000 sickle cell occurs in about every 36,000. It looks like I can barely read that. It looks like it's been cut off, but it's quite a few. So if we look at African American or African origin, that it also includes Middle Eastern, Indian, and Mediterranean descent, it's estimated that 1 in 13 children of African descent suffers from sickle cell trait. Sickle cell disease affects 1 in 365 individuals of African descent. In America, 100,000 individuals currently suffer from this disease. Newborns with a family positive for sickle cell disease should definitely undergo evaluation and screening to make sure that they do not have this. It just takes a blood test. So, what are the symptoms of sickle cell anemia? Of course, it's swelling of the hands and feet, pain, episodes of pain to various parts of their body, depending on where the clumping occurs. It usually manifests itself at 6 months of age when the hemoglobin levels begin to fall. The most, again, the most largest symptoms is fatigue and pain, and also infections due to the damage of the spleen. So that can lead to more spleen damage. Bone, chest, back, and joint pain, tachycardia, tachypnea, shortness of breath, fever, anxiety, malaise, gallstones, vision problems, leg ulcers, and possible stroke. There is an increased risk of infections due to spleen damage, though. Anemia, yes, sickle cells break apart and die easily. It doesn't transport hemoglobin like our regular cells do as well. Typical red cells usually live for 120 days before they need to be replaced, but sickle cells usually die in 10 to 20 days, and that leaves a shortage of red blood cells leading to anemia. Without enough red blood cells, the body can't get enough oxygen, and this is why the children have fatigue. They can also have chronic pain from bone and joint damage, ulcers, and other causes. Again, we can see swelling of hands and feet and frequent infections. Vision problems due to the small vessels and stuff in the eye, which can damage the portion of the eye called the retina and lead to vision problems. They can have retinal hemorrhages, and some people with sickle cell anemia will also have chronic pain from bone and joint damage. Um, they may have delayed growth or delayed puberty because of the fact that they don't have the nutrition and oxygen they need to have a healthy body. So let's look at the sickle cell anemia crisis or storm. Um, Sickle cell anemia crisis is used interchangeably between storm and crisis. It's to describe the severe episode of pain and complications associated with sickle cell. Pain develops when, of course, when the sickles themselves get together and clump together and they block off a certain area of a joint or body or abdomen, wherever they get into that area, and it causes severe pain. That requires a hospital stay. And typically, individuals who have had multiple episodes can get kind of used to this. Some individuals may have very few, but some of them have had multiple uh, episodes where they're in the hospital quite a long while. Those can be triggered by dehydration. Note there that they need to stay hydrated. They can be triggered by infections, extreme temperatures, stress, and physical exertion. During a sickle cell crisis, the cells obstruct blood flow and depriving that area of the tissue from nutrition and oxygen. The severity of that depends on where the clotting or the clumping occurs. So the more vital the organ or more vital the area, the more painful it can become. If it becomes a finger or a toe or something of that sort, it can actually lead to necrosis and loss of that extremity or that problem. It can, again, occlusive crisis. It can occur in the digits, and it's called dactylitis, where the finger becomes severely painful, red hot, and swollen. Of course, they can also have it in the abdomen. They can have it in the chest. They can have these pain areas and clumping areas anywhere in the body. So any organ, any tissue can be impacted, including gallbladders, stomachs, intestines, etc. Aplastic crisis is another significant manifestation of sickle cell, and that's when the presence of parovirus B19 challenges the already challenged bone marrow. And so it fails to generate the appropriate number of red blood cells, which can also result in severe anemia. So make sure that if you have got a family history of sickle cell, that you've been screened for that. Make sure your children are screened. Did you know that there are more than one way to inherit sickle cell? Again, you can have sickle cell uh, so many different ways there, it looks like. So early diagnosis at birth is very imperative. Management will involve pain relief, blood transfusions, and prevention, of course, of the crises, and management of pain, making sure that the person stays hydrated, IV fluids, oxygen therapy, and blood transfusions. So our focus of nursing care is going to be in managing the acute pain, preventing complications, and providing education. Medications, common treatments include blood transfusions, hydrourea and pain management, NSAIDs, over-the-counter medications, prescription opioids, and non-pharmacological approaches are available. As we go on down and look here, we can see that here's our ibuprofen, naproxen, and opioids that they're talking about for pain relief. Vitamin E seems to serve a role as an antioxidant and helps with that. So vitamin E and glutamine seems to be also helpful if they have low glutamine. That's used to treat sickle cell anemia and to help with the production of viable cells. Patient education, monitoring, making sure that the patient is getting their health care monitored and that they're seeing their physician that's monitoring and managing this condition. So we have patient education, clotting, mobility, pain, perfusion, and gas exchange are interrelated exemplars with this. Let's talk about deep vein thrombosis. We have a normal vein on the left here, and then we have a deep vein thrombosis with thrombolytic. As you can see, it changes the color of the legs and the extremities because of the thrombus. It is a serious condition where one or more blood clots form in your blood vessels. A thrombus is a blood clot. It's attached to the interior wall of an artery or vein, and it causes partial or complete blockage. By contrast, deep vein thrombosis occurs when a blood clot or thrombosis forms in one or more deep veins, usually in the legs, but they can also occur in their arms or other deep veins, and it impairs the blood returning to the heart. The pain is described as soreness or cramping. Pain in the legs is attributed to impaired tissue perfusion because of our peripheral artery disease and deep vein thrombosis. Atherosclerosis is a condition characterized by the buildup of plaque in the arteries, leading to narrowed arteries and reduced blood flow, which can result in serious cardiovascular complications as well. An arterial thrombus can occur in any artery, but the most common sites are the vessels of the heart and brain and the vessels of the legs. Blood clots that form within the deep veins are called deep vein thrombosis, DVT, and they produce pain, edema, and warmth. So that's our assessment. When we look at these patients' legs, they're going to have swelling, they're going to be red, and it's going to be painful and very warm to the touch, okay? And so we send that patient down to have an ultrasound so that they can check to see if where the clot is. The other kind of clot is a pulmonary embolus, and that's a clot when a clot has traveled to the lung, and those patients have severe changes in breathing. They have dyspnea suddenly with sharp pain, and it can have hemoptysis or coughing up of blood, and that's an emergency situation. I could see a question on the test right there. If they have shortness of breath, rapid onset with chest pain and hemoptysis, which is blood in the cough, when they cough up blood, is this a considered emergency situation? Yeah, it sure is. The highest rate of deep vein thrombosis is seen with patients who are immobile or on prolonged bed rest. So again, mobility serves our prevention. Get that patient moving. So what are the treatments, nursing interventions, and patient education? First of all, obstruction of an artery is an emergency because of the reduction of oxygen reaching those tissues. So we need to get oxygen and perfusion returned to those areas so they don't have any type of problems with the leg or losing the leg. So signs and symptoms will vary depending on what the degree of impairment is. Patients may report pain with walking, that's called claudication, that is relieved with rest. That is then called intermittent claudication. If they rest and it goes away, that's intermittent claudication. The pain indicates an inadequate blood supply to transport oxygen, which is needed to meet the demands of the leg and muscle during exertion. So when they rest and they no longer have the exertion or need for the oxygen, that's when the pain stops. So what are the key nursing interventions for management of DVT? Of course, number one is administering anticoagulants. The most common is warfarin. That's an oral anticoagulant, which prevents clot growth. Then again, heparin. That's the injectable one, as well as Lovenox, which may be injected into the stomach. Then promoting circulation. How are we going to promote circulation? Well, we're going to use it by using compressive therapy, such as TED hose, compression stockings, devices like SCDs, which is sequential compression devices that we use that we put around the person's legs that attaches to a machine, and then it actually massages or actually puts pressure back into the leg in order to continue with the blood flow and helps prevent further clot formation. And of course, number one for us is if that patient can get up and move around, is to get them up and moving, get them ambulating, get them to perform leg exercise, leg pumps. If they can't get out of bed, move those ankles, move the legs, move the knees, make sure that they're bending. Monitor for signs of DVT, such as swelling, pain, and redness in the affected limbs. So that's our number one the assessment when our patients are not moving around too much or when they're coming back from surgery. Make sure that they are getting up and moving around and that we've monitored for DVT. Vital signs, check for their vital signs, including their heart rate and blood pressure, to check any changes, listen to their heart, listen to their lungs, and then they will tell you if they're having a sudden change and oh gosh, it really hurts for me to breathe. I try to breathe and I can't hardly catch my breath. I'm hurting. Yeah, we might want to be checking for a PE. So patient education is also to educate them on what to look for. We're sending them home, then let's make sure that we've trained them what DVT and PE sound like or feel like and what the symptoms are that they should be seeing. And to make sure that they communicate that back to their doctor if they're seeing those signs and symptoms. If they're not able to get a hold of their doctor, then go to the emergency room so they can be evaluated. Again, sudden changes in chest pain or shortness of breath, they need to seek a medical attention immediately. Then we need to collaborate our care with our team. Make sure that the respiratory therapist, the physical therapist, the physician, we're all going to be working together to keep that patient from having these type of complications such as DVTs and PEs. But if we do have that happen, then we're working together in order to solve it. Okay, pulmonary embolism. Again, that's the blood clot lodging into the chest. Um, it will travel through, and sometimes it either lodges in the heart or lodges in the leg or sometimes into the lungs. And again, that's decreased perfusion. And that can also lead to death in these patients, especially if they have that frothy, blood-tinged sputum. I mean, they're coughing up this frothy sputum and it's blood tinged. I mean, that really tells you that this is a bad thing. We need to get a hold of an emergency crew. We need to get this patient back to the emergency room, or if we're in the hospital, get somebody up there to start assessing this patient right away because then they're going to be having cyanosis. They may end up having regular heart rate. Cyanosis, of course, is not enough blood oxygen is getting to their extremities, and they're having more dyspnea. The classic presentation, now you need to make note of this, is dyspnea, chest pain due to the blockage of the pulmonary arteries with emboli that travel from the venous system into the lungs. And then hemoptysis that occurs in 20% of the patients. So you may not always see them coughing up blood, but every 20% of patients will. And of course, again, chest pain, that pain with breathing. If they have a family history of DVT or PE, then this person is probably at a higher risk for PE and DVT as well. And if they have a bleeding disorder, we need to know that, especially if they've had a GI history of GI bleed or hemophilia. That can also increase their risk of PE. If they have had cancer, malignancy, lung cancer of any kind, or breast cancer, any type of cancer, and they've been on chemotherapy, they can have a DVT or PE. They're at a higher rate of occurrence for that. The treatment for pulmonary embolism, of course, is preventing the blood clot from growing and reducing the risk of new blood clots. So we're going to be putting them on blood thinners, and we're going to be monitoring their blood thinners. We're going to be making sure that their blood INR or PTT is being monitored depending on which blood thinner they're on. Heparin, again, is often administered IV via injection, and it is used in the hospital to quickly get ahead of that clot, to get it starting to break up, to keep it from having any further clots. Warfarin, that again, that's that oral anticoagulant that may be prescribed once they get home, and then they'll have to come back to have their blood tests from time to time. And then we have rivaroxaban and Eliquis that they may be on. Those don't have blood tests associated with them particularly, but we do need to every now and then check their hemoglobin and hematocrit and RBCs to make sure that everything is still okay and they're not anemic. When we use a thrombolytic, that is a clot buster, let me think of one here. It's like nattokinase or streptokinase. It has kinase in the name. Those are actually used to dissolve the clots, and that can sometimes be used in a life-threatening situation so that we can get ahead of it to help save a person's life. And then sometimes we'll put in a vena cava filter, IVC, that will go into the person's lower aorta or into the right above the femoral artery into the abdomen area where the aorta is bifurcating into the left and to the right femoral area. They'll put it in a filter there to catch the blood clots before they go anywhere. So know the definition and function of thrombolytics. Again, thrombolytics are known as clot-busting drugs, are a class of medications that work by breaking down blood clots or thrombi that obstruct blood vessels. This process, known as thrombolysis, helps restore normal blood flow, which is essential in preventing tissue damage and preserving organ function. Need to know that definition because it is highlighted. Also know ischemic stroke. Thrombolytics can be administered within a specific time, usually that's why we say if you have a stroke, note the time that your symptoms started. We only have a certain amount of time to get a thrombolytic in you if we can use it. Myocardial infarctions also are due to the clots, and if we know ahead of time, we can get them into the cath lab. We can get them open back up. We can get them stented, or we can get that clot busted. And then, of course, pulmonary embolism, thrombolytics can also be effective in treating those as well. So need to know them. Again, they are time sensitive. It is very important for us to know the time of an onset of the symptoms, and the patient needs to get to the hospital quickly. So they are used in an emergency situation. So what is our collaborative interventions for clotting disorders? Assessment. Again, sudden dyspnea, sudden sharp chest or upper abdominal pain. Cyanosis, which means their fingers are turning blue and their lips are turning blue. They don't have enough blood flow. Tachycardia, fast heart rate, a drop in blood pressure. Our interventions, again, notify the RN or surgeon because pulmonary embolism is life-threatening. Monitor the vital signs. Administer oxygen. Medications are used to treat that would be of importance. So the focus of the nursing interventions is to stabilize that patient. Get them up in the high Fowlers again if they're having difficulty breathing. Put them on oxygen, talk to the nurse, get the doctor in there. They need to get that patient assessed. They need to use a D-dimer or get them to the CT scanner or to some type of intervention so we know exactly what's going on. And again, supplement with oxygens, monitor their vital signs, making sure that we're giving them their anticoagulants and ensuring fluid balance, make sure they're taking their fluids. Because a lower volume can also aggravate the situation. Need to know if they can tolerate contrast media, make sure that they don't have any problems with contrast because they're going to probably go to a CT scanner and have contrast media. Make sure that, again, that we put on compression devices or stockings and that we are, again, ambulating that patient and educating that patient on the signs of and issues of that, of what the PE set looks like, what is the DVT, what are the symptoms that you will see. If they are on any type of Coumadin or any type of warfarin anticoagulant, we also need to be teaching them not to be eating vitamin K sources, high amounts of green leafy vegetables such as spinach, kale, mayonnaise, canola oil, and soybean oil. All of those have vitamin K in them, so they need to be watching how much they're using of that because they're counteracting the um, function of their blood thinner. Again, here's some pharmacotherapy. We've talked about warfarin, heparin, antiplatelets. What are the purposes of the lab values? The PT, PTT. Remember, PTT is for heparin, PT and INR is for Coumadin. Uh, Review that if you need to. Look at the notes that I have here. Lovenox, those medications. There's a bunch of medications in this particular presentation. I would go back through this presentation, look at these notes, and again, get these medications down, such as the Lovenox, the Fragment, these medications that you don't know that may be on this next test, aspirin, Plavix, etc. Make sure you've got these, Pradaxa. So look at these notes, know what they are, know where the medications are, what they do, and what the nursing considerations are. There's a lot of information in this, and I don't have time to give it to you. I'm already running over time as it is with this presentation. So pulmonary embolism, emergency and surgical intervention, again, they're going to get fluids. They're going to get some type of clot busting medication. If it's indicated, TPA is the name of that particular clot busting. So it's all based on whether or not they have the size of the clot, where it's located, and what type of symptoms they are having. Thrombolytic agents such as alteplase, ALTEPLASE. Again, I mentioned the kinase ASE. That's what we're talking about. All of these are types of thrombolytic agents, and Retivase is the one of the others. Again, more meds, more meds, more meds. Those are important because they cut down, they save lives. If we get those into you, and we can get the clotting broken away, where we can get that so it's no longer clotting that area of the brain or clotting that area of your lung, then you can start breathing again. And so that's the whole goal of treatment is to preserve life and to preserve the patient. Okay, lots of questions, I'm sure. Take a look at these NCLEX practice questions. Again, a LPN is collecting data on a patient who's receiving iron supplements for iron deficiency anemia. Which assessment finding would the nurse report to the RN immediately? And again, you would need to look at these. Now, yeah, I would. Again, this is an anemia, and I don't know why they have black tarry stools up there. That means that they're having bleeding in their gut. Mild nausea after taking the medication. Well, that's iron. That's the normal side effect of iron happens to be that. And black tarry stools are also a known component of getting iron. Iron actually causes you to have black tarry stools, so it may not be a sign of bleeding. But the most important one here is pallor, tachycardia, and hypotension. So we're talking about a person who has paleness, their heart is beating fast, and they've had a drop in their blood pressure. Yeah, that would be worrisome. The next one here, 35-year-old male with hemophilia preparing for dental cleaning appointment. What is appropriate is basically looking at this, we want to make certain that he shares that information. I think is more important. We do not want to have him take aspirin. That will just cause him to bleed more. We don't want him to use a firm bristle toothbrush. We tell him to use a soft bristle toothbrush. And says just getting a tattoo instead of dental work? No, because he's going to end up bleeding to death when he has the tattoo placed. So the only answer that makes sense is C. The next one, a 22-year-old patient admitted to the hospital with sickle cell crisis, complaining of severe pain, which nursing intervention should receive highest priority. Yeah, we're going to give this patient some fluids eventually here, but that's not our priority right now. Our biggest priority, yes, we should monitor vital signs, and yeah, we probably will apply warm compresses, but let's get his pain under control first. I mean, he's in severe pain. If you've ever seen a person in sickle cell crisis, you'll never forget it. I've unfortunately had a few patients who have had sickle cell crisis, and the one I remember the most, of course, is the 10-year-old I had when I was working at Methodist. And she was a return patient. I saw her a couple of times while I was there. A patient with sickle cell crisis presents to the emergency department, which with shortness of breath, pain, and needs to go to the bathroom. Which nursing action should receive the highest prize? Prize again. Probably again. Remember Maslow's hierarchy of needs, and remember the ABCs. Our biggest priority, especially if they're in sickle cell, is not going to be whether or not they get to the bathroom right at this moment. It's not going to be starting IV fluids, or in this instance, administering pain medicine, because they're not in. They are probably. We need to assess the respiratory. If you haven't guessed that by now, it's the ABCs of airway, so always assess. If they throw an answer at you that says check the status and oxygen saturation, you may want to look at that one as being a priority because it does fit the ABCs. 45-year-old patient presents to the emergency department with sudden onset of pain, shortness of breath, and anxiety, which assessment finding would most strongly suggest PE. Now, it's not gradual onset of symptoms, and it's not normal oxygen saturation on room air. Yeah, you got it. Pleuritic chest pain with tachypnea and tachycardia. They're going to be breathing heavy, breathing hard, and having tachycardia. Now, and productive cough of yellow sputum. No, you don't have any type of yellow sputum production with a PE. Frothy with blood tinged, yes. And then that way we would say, that's biggie. But it's not that one. It happens to be the pleuritic chest pain. A nurse is assessing a patient with compromised tissue perfusion, which assessment finding indicates the most serious complication. Think necrosis of the skin. Yeah. If they have tissue necrosis of an affected area, that means that they have tissue that is dying. That's what necrosis means. That means this. That's the most serious thing that we have to worry about is that represents irreversible cell death of an area if it's necrotic. And the last one here is if nurse is caring for a 12-year-old with sickle cell admitted with vaso-occlusive crisis, which factor would the nurse identify as most likely to have precipitated this crisis? So they've had increased fluid intake over the past 24 hours, not quite. Let's go down to C, administration of supplemental oxygen at home, nah. Consumption of a high protein diet, probably not. Yeah, recent exposure to cold temperatures, yes, that happens to be one of the predisposing factors that increase sickle cell disease crisis or sickle cell issues, is that cold, being out in the cold temperatures. Thank you so much for listening. I'm sorry that this is a real long one, but I want to make sure you have all the information. Again, perfusion is a very huge topic and it's a very big topic. I thank you so much for your time and I thank you for listening. If you have any questions or concerns, don't hesitate to get a hold of me. I'll be posting this on SurePath as well as it will be on YouTube. Thank you.